Every single QI, no matter what it measures, is built exactly the same way. Okay. That's unfortunate. Sounds good. Thank you for letting me know. Don't you just hate when your computer does an update in the middle of a session? All right. So looking at this, okay. So first, okay, CAHI decides who should not be counted, right? Because for some residents, the outcome is expected or not appropriate to measure. And then it looks at everyone else. So that's your denominator. And the next, it counts one very specific outcome, and that's our numerator. And it turns that into a percentage, right? And that percentage, it's not a grade, right? It's not a pass or a fail. It's a performance score. It's a pattern. High or low is not good or bad on its own. It tells us where we should pause, right? And ask better questions. So we're going to start, and as we go through the prevalence indicators, I want you to focus less on the number and more on what that number might be trying to tell us about our population. So a quick view here, okay? The slide introduces the 12 prevalence indicator that are tracked in the Inter-I LTCF system, right? We're measuring existing condition observed at the time of assessment. They're not about, okay, improving or declining. They reflect issues at the present and ongoing, giving us a snapshot of that resident's health status, right? And those clinical indicators, right? They span across a whole bunch of clinical areas: continence, urinary infection, delirium, psychiatric, medication use, falls, infections, feeding tubes, weight loss, pain, pressure ulcers, and of course, physical restraints. So each one of these indicators, right, it helps identify opportunities for quality improvement, risk education, and resident safety monitoring. Okay, so I'm going to walk you through each of these 12 indicators one by one. We're going to look at what they measure, who it includes, who it excludes, and how are they calculated, right? So, percentage of residents with indwelling catheters. This quality indicator tracks the percentage of residents using an indwelling urinary catheter at the time of assessment, right? So the goal here is sorry, to monitor catheter use as prolonged or inappropriate catheterization can increase the risk of infection, reduce mobility, negatively impact their quality of life. So let's look at the calculation. So we start with, and almost all of them have exclusion factors. So we had the previous, so we looked at general exclusion factors, right? So if the assessment is done within the first 92 days, we're not even looking at this. We're not looking at the assessment. However, if the assessment qualifies, so we're going to look at this assessment. So now the system goes, all right, let's look at for the quality indicator of indwelling catheters. Before they look for numerators, they're going to look at the denominators. How many people can we trigger for this quality indicator? I have 100 people in my home. I'm going to look for these things, exclusion factors. Is any of the data missing for bladder? Is end stage disease coded as yes? Is hospice program coded as yes? So if I have 100 residents, I have two of them on end stage and hospice, then only 98 of them will be part of my denominator, right? Or not to make this more complicated, if I have 100 people, I have five of them who were admitted in the last 90 days. So now I'm only looking at 95 of them. Out of those 95, two of them are end stage. So now I'm only looking at 93 of them. So there's a two-tier exclusion, right? General exclusion, we're not going to look at your assessment. And then individual by the resident, by the quality indicator. So these two are not present, then you're part of that denominator. Who triggered this? Residents with the indwelling catheter. So if I have one here, I have 100 here, then I have a 1%, right? If I have five, I have 5%. Then it goes to high, it looks at four quarters, it statistically adjusts, and I end up with a quality indicator of 6%. It can make it worse, it can make it better, it could make it the same, right? A, so once I have my numerator, my denominator, I use my high school math, and I'm good to go. So a higher rate here, right, may indicate issues with continence management, right, or overuse of catheters, maybe gaps in restorative care planning. So reducing that unnecessary catheter use is a key improvement goal across long-term care facilities. So here we're tracking the percentage of residents who had a UTI within the last 30 days. It's a very important measure of infection control and overall care quality, right? Especially in residents with incontinence or indwelling catheters. So for our calculations, okay, we have the exact same exclusion factors. So first, we make sure that the assessment qualifies. The assessment qualifies, perfect. Then we're going to look, are they end-stage disease? No. Are they hospice? No. Then they are part of the denominator. So I'm going to look at everybody who's in the denominator. Any of them have a UTI, right? So 1, 2, or 3 at I1S, you are in the numerator. And tracking this quality indicator, right? It helps the facilities monitor trends, identify areas to improve infection prevention, hydration management, continence care protocols. This quality indicator measures the percentage of residents that are showing signs of delirium, right? Which is a sudden and severe disturbance in mental abilities, right? So delirium is often under-recognized, okay, but it can indicate serious underlying issues, okay, infections, dehydration, medication side effects, acute medical crisis. So if we look at the calculation, so we can see here we have quite a few exclusions, right? If your daily decision making is missing or you're comatose, right? There's no movement. If you're palliative, okay, if data is missing, if you're end stage disease, hospice care, and then if your previous data is missing and your present is greater than zero, they're gonna exclude you. So here, okay, in if you're not excluded, all the data is there, right? You're part of that denominator. We're going to look at your assessment. So there's three things here. So the behavior is present and appears different from usual. So C3A, B, or C is a 2, or C4 is a 1. So your acute change is there. That will make you part of the numerator. If your behavior is a 1, it's present, okay? But in the previous assessment, it appears different. You're going to code for delirium. If it's present and previously, okay, you had a CPS score of 0, okay, it was 0 previously, and your cognitive performance scale saying that you're good with decision making. So you did not have issues, you're cognitively sound, and now you're showing something, you're going to trigger this quality indicator. So in long-term care, this indicator is especially valuable, right, for identifying those residents who may be experiencing that acute change, okay, that requires immediate clinical attention. So facilities will use this QI to flag those possible undiagnosed infections or medication-related complications. Trigger medical or interdisciplinary reviews. Support early intervention strategies, right, to try and reduce hospital transfers, reduce falls, okay, functional decline. High rates of delirium should definitely prompt a closer look at environmental, clinical, medication-related factors within your home. Okay. Percentage of residents receiving antipsychotic medications without a diagnosis of psychosis. So this indicator has received a lot of attention across the sector because it reflects that, a key area of quality and safety. So, and it's looking at appropriate use of those high risk medications. So when we're looking at the exclusion factors, schizophrenia, end stage disease, palliative. If you said they had Huntington's disease, delusions, hallucinations, okay, or if you did not answer the question about antipsychotics. So if the assessment qualifies, right, we always start with our general exclusions. Assessment qualifies. Are any of these present? If they are not on that resident, then that resident is part of the denominator. Yeah, we're going to look at you. You're going to be part of our numbers. If you've received a antipsychotic in the last 7 days, you've triggered this quality indicator, okay? Again, if you have schizophrenia, end-stage palliative, Huntington, delusion, or hallucination, they're not going to look at you. They're going to take that assessment and put it aside. I have 100 assessments, 100 residents. 10 of them have schizophrenia. Well, I'm only going to look at 90 of them. I'm going to take those 10 and they're not even part of that calculation. Right? And it flags, right, for that potential overuse or misuse of those antipsychotics. We use these to audit medication practices, to trigger medication reviews, especially for residents without that clear psychiatric diagnosis. So we monitor progress, right, towards reducing inappropriate antipsychotic use, which is also a focus, right, of that provincial accountability and public reporting. So it's about promoting non-pharmacological approaches first, especially for managing responsive behaviors, right? Making sure that medications are only used when clinically appropriate and well documented. Okay, residents who experience one or more falls in the last 30 days. So calculation pretty straightforward. So if any of the fall data is missing, they're not going to calculate, but there's no other exclusions. Even if you're end stage disease, even if you're palliative, if you fall, you will be part of that numerator. So as long as all of your section of data is completed, you will be part of that calculation. Okay, if you've had multiple falls the last 30 days, you trigger. So this indicator is important because it gives us insight into how well we are managing fall prevention strategies in our home, right? A high fall rate may signal issues with mobility support, maybe medication management, maybe it's environmental safety. Okay, it's also one of those indicators that is publicly reported in the Health Quality Ontario. So it plays a key role in how facilities are evaluated on that resident safety outcomes. All right, tracking new or worsening respiratory conditions among residents. So this one is important, right? Because respiratory issues like pneumonia, shortness of breath, dyspnea, or aspiration are significant contributors to that functional decline, hospitalization, mortality in long-term care. So how is this calculated? We're going to look at exclusion factors. So if any of the data is missing, of course, any of the previous data is missing. So that's important as well. So they developed a new respiratory condition, so had no prior issues, and now they have one, or they had it before and they still have it. So that includes people with on palliative care, that includes people with end stage disease. So if all of your data is completed, nothing's missing, then you're not excluded, right? There's not too many exclusions on this one. So, but we're still going to look at the general exclusions first, right? Does the assessment qualify? If it doesn't, we're not even getting to these. So if you're not excluded, you're part of the calculation. If you have a new or still existing, okay, pneumonia, dyspnea, or aspiration, you are part of that numerator. So homes use this to monitor the effectiveness of respiratory care strategies, right? Such as infection prevention, suctioning protocols, hydration support, early identification of respiratory decline. If your rate is trending high, it may signal a need to evaluate your clinical assessments or care interventions related to the pulmonary health. All right, the use of feeding tubes among residents in long-term care. Um, so if we quickly look at the calculation here, so if you're comatose, if you're end stage disease, you're palliative, or you didn't answer the question, you're not going to be part of the denominator because you're excluded. Numerator, that's pretty easy. You count people with the feeding tube. Now, you would think this is a simple. So just one story here. Dr. Paul and I, we were consulting with a home, and they were they were looking at their Chi-High numbers, and they had their feeding tubes at 32%. So, and she was like, "How is that possible? I have one person with a feeding tube." Now, mind you, that was a very small home. So the less amount of beds, the bigger the impact of one. Now, taking the exclusion factors, removing some of them, and then using the risk adjustment from the province, gave them a 32%. Now, this is an extreme example. However, it is a true example. This happened. So it was important to put some context behind it. So why does this indicator matter, right? Feeding tubes are sometimes necessary. However, they should be used thoughtfully. High rates can prompt further investigation into care planning, into informed consent, whether alternatives like modified diets or supportive feeding strategies have been tried. Facilities may also use this indicator to monitor alignment with the residents' goals of care, especially with those with advanced dementia. Okay, it supports ethical decision making. It promotes that resident centered care. It helps us reflect on whether the tube is being applied appropriately, ethically. All right. So here we're looking at percentage of residents who have experienced unexplained weight loss. And that is a key clinical concern in long-term care. So if we look at the calculation, and they did a change with this compared to when it was in the CCRs that I'm not happy with. They had no choice because one of the questions that was in the CCRS no longer exists in the LTCF, right? In the CCRS, if you remember, there was a question where resident is on a planned weight loss program, and you would check that off if they were on a planned weight loss program by the dietitian. And then when you click that, it would exclude you from this quality indicator because they want him to lose weight. So we're not going to say this is a quality issue. It's the opposite, right? It's good. But they've removed that question is no longer in the LTCF. So now, even if they're on a planned weight loss program and you indicate that they have lost weight, they're going to say you have unexplained weight loss. In the grand scheme of things, does it do a big change? Probably not. However, I thought it was a very, uh, they did not have it in the 24, they implemented it with the 35, and now they've removed it for the 34. It is what it is. All right. So how are we calculating this one? Pretty straightforward. End stage palliative, if you did not answer the weight loss, then you're excluded. You're not part of the denominator. If you're not one of these, you are calculated, right? Did you tick off K2A? Yeah, you're part of that numerator, meaning you will be part of that percentage, right? And it's important. Unintended or unexplained weight loss, right, can be a red flag. It can signal poor nutritional intake, underlying disease, depression, swallowing difficulties, or even neglect. It's often an early indicator of functional or clinical decline. So this QI gives the team a chance to intervene before issues escalate. Facilities may use this indicator to review care planning, dietary supports, staff awareness, follow up actions, right? Especially for residents who are frail or at risk for malnutrition. It's not just about the number, it's about the story behind that weight loss and what we do next to support the resident. All right, now we're focusing on the prevalence of moderate to severe pain among long-term care residents, right? A critical marker for, of comfort and well-being. So if we look at how this one is built, right? So we start with and this one, there's no exclusions for palliative for end stage, right? Pain is pain, doesn't matter where you are in your disease progression. So if it's missing, we can't calculate it. If your frequency is answered, but your intensity is missing. The other exclusion is if you said there's no pain, however, you put an intensity, so there's an inconsistency here. You can't have intensity if you have no pain. So either of these three means we're not going to look at you. Everyone else, you are part of that calculation. So they experience daily pain with a moderate intensity, or so that will make you part of the numerator, or you have severe excruciating pain. So if your pain is severe or excruciating, they're not looking at the frequency. You're automatically part of that quality indicator. So, and we know, right? Pain is not just a symptom, right? It's a quality of life issue. If it's left unaddressed, pain can lead to functional decline, to mood disturbances, to sleep disruption, and even to, resistance to care. So we use this QI, right, to monitor pain management effectiveness. We're going to try and flag gaps in assessment or follow-ups. Make sure we evaluate whether residents are receiving adequate interventions, whether it's medication reviews, therapy, changes in their care plan. So ultimately, right, this indicator reflects how well we are supporting comfort and dignity, right? And these are cornerstones of that resident-centered care. All right, prevalence of more severe pressure ulcers, right? Stage 2 or higher. And these are not, we're not talking about superficial wounds here, right? They reflect a deeper tissue damage and carry a significant risk of complications, whether it's infection, delayed healing, pain. So if we look at the structure quickly, the only exclusions are those general factors, right? Are we looking at the assessment? Yeah, then you're included. You're part of the denominator. If your most severe is equal to 2 or greater, so 2, 3, 4, 5. So pretty simple to calculate, right? If you have a 2 or more, you are part of that calculation. And this QI, right, is a direct reflection of skincare and pressure injury prevention practices, right? So higher rates might signal inadequate repositioning or offloading protocols, gaps in nutrition or hydration, poor moisture management, or delays in identifying early stage skin breakdown. So tracking this over time really helps the home monitor, right? The effectiveness of prevention strategies, guide staff training needs, making sure early interventions, okay? Pressure ulcers are largely preventable. So this indicator often becomes a big focus in those quality improvement plans, especially during compliance audits and public reporting. So newly occurring stage 2 to 4. Exclusion factors, if L1's missing, okay, or in your previous assessment, okay, in your previous assessment, your most severe pressure ulcer was 2 or higher. So if you already had a 2 or higher before, then there's no point. Like it's not a new 2 to 4. So if you did not have a stage 2 to 4 on the prior assessment, you have one now, we're going to look at you, right? So L1, the most severe, is 2 or higher, and previously it was 1 or less. So they did not have a stage 2 or higher. Now they do. You trigger this quality indicator. Now, um, we use this, right? It's incredibly important. It also directly measures the effectiveness of those prevention strategies. A high rate may indicate a breakdown in that early detection and the risk assessment, right? Interventions like turning schedules, mattress use, skin monitoring. This one is often tied into staff performance reviews, quality improvement plans, and internal audits. It also helps target your at-risk population for more intensive monitoring and then align with that Health Quality Ontario reporting metric, those benchmarks. Okay, it's not just about wound care. This one, right? It's a marker for the broader quality of daily care routines. It supports skin health and prevents decline. Now, this one feels a little different because it uses a previous assessment, and that's intentional, right? CAHI is not measuring how fast a pressure ulcers are occurring. They're asking right now how many have a stage 2 to 4 that wasn't there before. So, the previous this is a prevalence indicator, but the previous assessment is basically just a reference point, right? It helps define what new means, but the calculation itself is still a snapshot of what's going on now. So that is why it remains a prevalence indicator. Or to look at it simply, it's a prevalence indicator with a memory. All right, our last prevalence indicator, okay, residents who are restrained daily using physical methods such as trunk restraint or chair that prevents rising. So if we look at the calculations, okay, we'll start with our exclusion factors. So we're going to look at daily decision making. So if it's a 5, meaning they're comatose, right? So we're not going to look at that one. If they have quadriplegia, we're not going to look at that one. If any of this data is missing, trunk or chair, they're not going to look at it. Now, hypothetically, technically, or logically, if someone has quadriplegia, right, then you should not have ticked off that they're restrained. So this exclusion is there for nothing. It's there in case you ticked it off. We want to make sure we don't target you for that quality indicator when someone is quadriplegia. If you put that trunk restraint or that chair prevents rising, even though they could not move on their own. So if they're not quadriplegic and they're not comatose, they will look at you and you will be part of that denominator. If your restraints are coded at 2 or greater, okay, so daily, we look at 1. So yeah, so 1 is use less than daily. So as soon as a restraint is used daily, you will be part of that numerator. And in long-term care, the use of physical restraint is widely discouraged. Not only are they linked to serious risk, like pressure injuries, agitation, and loss of mobility, but they also raise ethical concerns related to resident autonomy and dignity. So this indicator helps facilities to identify how often restraint use is occurring and whether policies or interventions are truly effective in promoting that restraint-free care, right? A higher rate often triggers regulatory scrutiny and flags potential gaps in staff training and care planning. So ultimately, the goal here, right, is to reduce, ideally in a perfect world, to eliminate, okay, that routine restraint use wherever possible, whether by using alternatives, whether it's restorative care, mobility programs, individualized behavior supports. All right. Which of the following best defines a prevalence quality indicator in the Interride LTCF? It measures the number of residents whose condition improved over a quarter. It tracks the onset of a new condition between assessments. It identifies the proportion of residents with a condition at the time of assessment. It calculates the average number of residents affected over a 12-month period. Is everybody away from their desk? No. Correct. Oh, the indicator PRU09, new stage 2 to 4 pressure ulcer, is categorized as a prevalence indicator. Despite tracking new cases, right? Remember, it's a prevalence indicator with the memory. Which of the following is a prevalence quality indicator? Percentage of residents whose ADL self-performance worsened, whose ability to communicate improved, with an indwelling catheter, whose pain worsened. The percentage of residents in daily physical restraint is an example of a decline indicator. True or false? Okay. Improvement incidence indicators. So we're shifting the focus to those improvement, okay? And these are one of the most empowering and motivating groups of quality indicators that we track. So unlike the prevalence or the decline, okay, that flag existing or worsening issues, these here indicators spotlight a positive change. Okay, they highlight residents who have actually shown measurable improvement in those specific clinical or functional areas between those two assessments. Okay, we're doing every domain: daily activities, daily living, behavior, continence, cognitive function, communication, mobility, right? Did the resident get better in this area over the past quarter? Okay, and it's important to remember that these indicators are based on the Interrise longitudinal tracking logic. Okay, meaning that a valid comparison must exist between this assessment and the prior one. So the right time frames and data completeness are essential. right? And these matter, right? Because they help shift the mindset from maintenance to potential. They allow care teams to identify where their interventions are making a real difference. For example, if your physiotherapy program is working, okay, then you might see an improvement in mobility or in ADLs. If your behavior management strategies are effective, maybe you'll see gains in behavioral symptom reduction. So, in short, these are indicators of success. Okay. And they help reinforce that positive outcome, and they are absolutely possible in long term care settings. Even when we're talking about our residents who have complex care needs. So we're going to walk through, each of them individually again. But before we dive into that okay, um, into the ADL improvement indicators, okay, we're going to understand, um, they're using again those temporary values, right? And we've seen these a little bit in before. So they're derived from those specific items in section G2 of the assessment. Okay, we see them all here on the screen. So they reflect the resident's functional performance in daily activities, dressing, toileting, transferring, mobility, all that. Again, in the last 3 days, right? Now, if you notice here, okay, um, dressing upper and lower body are they actually combine them again into a single variable. So it just helps streamline the data for the analysis and the indicator calculation. Now, for all of these, all right, we see what those numbers are transferred to because we can code anywhere from 0 to 8. So if they're a 6 to 8, counts as a 4. Because when we're going to go through the calculations of the quality indicators, we're always going to use from 0 to 4. We're not going to use from 0 to 8. Remember in the CCRS, it was 0 to 4 for the A side, the resident performance, and then the B side, the support provided was 0 to 4 as well. So they were always 0 to 4s. Now we're using 0 to 8 just on the one item, so they're converting them into 0 to 4. So they feed directly into the logic for the ADL related quality indicators. So let's start. Okay. We're looking at mid-loss ADL function, and that includes walking, locomotion, and toilet transfer. So these are essential for resident mobility and independence. So tracking, improvement here gives us meaningful insight into functional recovery. It captures residents who either improved in one or more of these areas, or very importantly, like it says in the title, who remain completely independent between their current and previous assessment. So even though they technically did not get better, they're still giving you credit for it, for staying independent. So if we look at the calculations, all right, we're going to start with our exclusion factors. If daily decision making is a 5, end stage disease, palliative care, if your information is missing, or if your previous information is missing, right, previous assessment, then you're excluded and you will not be part of the denominator. If you don't have any of these, then we're going to look at you. We're going to add all three items. How are we adding them? We're adding the 0 to 4 numbers, right? Because we converted all of those from 0 to 8 to a 0 to 4. Okay, we're talking about walking, locomotion, and transfer to toilet. If the total is lower than the previous assessment, then the person is included because they improved. Now, when we're looking at these numbers, okay, so we're looking 0 to 12 here. These are, again, a disability scale. So if they have decreased, that means they've improved, right? The lower the number, the better they are performing. So if the number is lower than previous, then they have improved. So they will be part of the numerator. The other way is if you are independent. So out of the 12, your score is 0. And previously you were a 0 as well. So you remain completely independent. You're also they're giving you credit for being independent in the last assessment and staying independent for this. You technically did not improve, but you stayed independent, so they're giving you credit. This is a quality indicator that you want to trigger, right? The higher this is, the better it is. So this QI helps us monitor how well interventions like restorative care, physiotherapy are helping residents regain or maintain independence in those key mobility functions. It can also indicate whether your care team is effectively supporting functional goal outline in care plans. All right, early loss function. Okay, so we're talking about personal hygiene and dressing. And these are typically the first areas of decline that we see in residents, right? So identifying and supporting improvement here again is critical for trying to slow that functional deterioration. So, again, they track those that improve. However, also those that remain completely independent across those two assessments. So these are the exact same exclusions, right? Coma, end stage, palliative, data missing now, data missing previously. We take personal hygiene and dressing, we code them, we transfer, we get that temporary variable from 0 to 4, 0 to 4. So we're coding between 0 and 8. If your total is lower than the previous, then the person has improved and they're included in the numerator. If they were independent, if they are and they were, they're in the numerator. So both ways that you can be part, or you will trigger this quality indicator, right? And this is particularly helpful for evaluating how effective restorative care or personal support programs are in helping residents retain independence in basic self-care, right? It's a great early, signal to monitor care quality and personalize interventions before more significant decline sets in. Now here we're focusing on improvement, but in late loss ADL functions. So these are among the last abilities to decline. Okay, so we're talking about toilet use, we're talking about bed mobility, we're talking about transferring on a toilet, and we're talking about eating. So they're all essential for maintaining, dignity and quality of life. So if we look at the calculation for this one, it's a little different. So we're going to start with our exclusion, which are the same. Data missing, missing. There's a new exclusion here, okay? The other two ADLs we just looked at, if they were independent in the previous one and they were still independent, they would give you credit for that quality indicator. In this case, they don't. For the late loss, they don't. So if your previous was 0, you were already independent, then you're not going to be part of the denominator. You are excluded. So for sure, someone who's independent in the previous assessment will not even be part of the calculation of the next one. Now we're looking at all 4 temporary variables, so all 4, right? Transfer, toilet use, bed, and eating. There's 2 scenarios, okay? Both of them are listed here. If 2 items decrease by 1, so for a total of 2, or if one of them decreases by 2 for a total of 2. So we're looking for a difference of 2. So these are example. If previously you had 3, 3, 3, 3 for a total of 12, and now you have 2, 2, 3, 3. So your number has decreased, so you've improved. If they're all threes and now one of them's a 1, right? So it's decreased, so you've improved. As long as you've improved by a factor of 2 on your total for the late loss ADLs. This indicator is especially useful when you're assessing the effectiveness of your restorative care programs and staff interventions. If you're seeing positive trends, it's a strong signal that your team is supporting residents effectively in regaining function, not necessarily just maintaining it. It also provides valuable evidence of quality when families ask, are residents actually improving here? This is one of the ways that we show that yes, improvement is possible and it's actually being tracked as well. All right, behavior variables. Okay, so what they did here, okay, we're looking at section A, those behaviors. Okay, and then when we're looking at socially appropriate and inappropriate sexual behavior, um, if we follow the trend here, the higher the 2 is what you're going to end up with as a temporary value. So the item coded the highest between the 2 is the value that is used for the combined variable. So when we're calculating this quality indicator, we're only using one value for these 2. We're combining them together. So it measures, right, that meaningful improvement in behavioral symptoms. Again, a vital area of care in long-term care setting where responsive behaviors can significantly impact quality of life and safety. So if we look at the calculation here, daily decision making, right? You're not comatose. And looking at our behaviors, the data is not missing. And we see wandering, verbal, physical, and then these two are combined, right, as a one. So that's why it says we're looking at 4 items. So 1, 2, 3, and then this is 4. We're looking at that as a one that we just saw in the previous slide. So if any of the 4 item has a value greater than 0, then you add a 1. So we're looking for a 0 to 4, right? We're not adding them all up. So if your current total is lower than your previous, you've improved, right? Again, these are all disability scales. So if you got lower, it's a good thing because you're getting better. You're part of the calculation if you're not excluded. Okay, continent variable, same thing. Okay, what they did here is they switched the 0 to 8 to a 0 to 4 for the bladder and a 0 to 4 for the bowel. So they're not looking at this, they're only looking at this to calculate, right? So, and it's important to understand this because when you're looking at your QI, why did it trigger like this? If you're trying to find the number 3, it's not in any report. The number 3 comes out of the number 4 from your bladder continence. Okay, so it really helps if you're ever going to investigate and you're going to, drill down to all of them. If you have a very aggressive program, you're trying to work on incontinence. So the bowel continence improve, right? Helps us monitor residents who show improvement in bowel continence. So if we look at the calculation, okay, and again, we're using those temporary variables, right? So we're looking at the same exclusions. So daily decision making if you're comatose, end stage palliative. Now, if previously you were as 0, so you were completely continent, you cannot improve. So you will be excluded, and we're not even going to put you in the numbers. If data is missing. And if you have an ostomy, you're not part of the denominator either. So you don't have an exclusion, then you are part of the calculation. You can trigger this quality indicator. If your current score is lower than the prior score, you've improved. Okay, we're looking for that 0 to 4, right? Temporary value. And this indicator is especially helpful for tracking interventions aimed at bowel management, whether it's diet changes, toilet schedules, medication reviews, or ensuring that they're having a measurable impact over time. Now we're focusing on residents who show improvement in bladder. So same thing here, same type of calculation, right? We're using our temporary variable, same exclusions, except this one we're looking at the bladder temporary variable. If it was 0, meaning they were, right, continent and they're still continent, then you're If they were continent, you can't get better. So we're going to remove that assessment from the calculation. So if your current score is lower than the previous score, again, you have improved. So disability scale number goes down, you're doing better. And this as well can show if your programs are effective, right? Exactly the same as the bowel. All right, we're measuring here how many residents have shown improvement in their cognitive function, right? And this is strictly based on their cognitive performance scale, right? The CPS. So pretty straightforward. We have some exclusion factors. They're the frequent flyers, right? Daily decision making is your comatose. Your end stage disease, palliative care, the data's missing previously or it's missing now. Now, the different one here is if your CPS score in the previous assessment was 0, meaning you were cognitively intact totally, you cannot improve for that. So we're not going to use that assessment in the calculation. If your current CPS score is lower than the previous one, then you have improved. You will be part of that quality indicator. You were a 4 3 months ago. They've adjusted your medication since then, and now you're a 3. Your CPS score is lower, meaning your cognition is better. So you will be part, okay? Again, all of these improved indicators, you want higher numbers, right? You want to show improvement as much as possible, right? Communication variables, same thing. All they're doing here is they are converting the 0 to 4 to a 0 to 3, 0 to 4 to a 0 to 3 for making self-understood and ability to understand others. So when we're looking at the calculation in the quality indicator, we're only going to see numbers 0 to 3. So it tracks improvements in residents' communication abilities, okay? Specifically, their ability to make themselves understood and to understand others. Key markers, right, of resident engagement and quality of life. So to evaluate this, we use the again, our temporary variables. We look at our calculation, right? Comatose, end stage, palliative, data missing now, data missing previously. That being said, this last exclusion factor here, if your previous assessment, right, your previous communication score, right, was a 0, then you can't get better. Um, If you're not excluded, you are part of the calculation. We add both of these together. So 0 to 6, because we changed that 0 to 4 to 1 to 3, right? To 0 to 3. So again, same thing. If your current score is lower than the prior, you have improved. So we use this, when we're planning care interventions, like speech therapy, cognitive stimulation, and even staff training on communication strategies. It's a great flag for both resident recovery potential and responsiveness of our care plans. All right, this one here, quality indicator that measures whether a resident's ability to move around, either within their room or unit, has improved between assessment, okay? And we're using the temporary variable for locomotion, okay? That reflects the resident's locomotion performance, but now from 0 to 8, it uses that 0 to 4. So if we look at the calculation here again, daily decision making and stage palliative, if the previous was 0, meaning they walked around on their own in the previous assessment. So if they walked around on their own, we're not even looking at them at all. They're excluded. If the current data is missing or the previous data is missing. And we say current or previous because we're always looking at the previous to compare this one, right? Now, if your current score, and then here we're only looking 0 to 4, right? There's only one item, is lower than the prior, then we have improved, and we're part of that. And this gives us insight into how many residents have regained or improved their ability to mobilize, okay? And this is directly tied to that quality of life, to the falls risk, to the discharge potential, so it can highlight the impact of our interventions, whether it's physiotherapy, mobility aids, care planning efforts aimed at preserving independence. Couple of questions here before we get to the decline indicator. So, which of the following is a valid improvement quality indicator? Percentage of residents whose bladder continence worsen, mood from symptoms of depression worsen, cognitive ability improve, pressure ulcer progress to stage 2 to 4. This one is pretty straightforward, right? DEHI4 measures improvement in behavioral symptoms using temporary continence variables. True or false? And BEH is a behavior. It uses temporary variables, just not the continence ones, right? So this is false. A little bit of a trick question. So these are the type of questions we're going to see on the exam. And I will talk about the exam at the end of today. So we don't have to worry about that. All right. So we looked at the indicators that focused on improvement, right? So now what we're doing is we're shifting our attention to the decline incident indicators. These indicators track residents whose health or functional status has worsened over time, right, since the last assessment. So essentially, it's helping us identify where deterioration is occurring, and where interventions may be needed the most. Okay, so they are essential for quality monitoring, and help us ask the right questions, right? Are there preventable declines that we can mitigate? Are residents experiencing avoidable worsening, whether it's ADL, behavior, continence? How can we care plan, right? How can the care plans be adjusted to address these risks proactively? So this is the largest one, all right? We have 13 decline incident indicators. And the CCRS, we had 14, now we have 13, okay? And they cover the whole spectrum of resident outcomes, right? Behaviors, continence, ADL, communication, cognition, mood, pressure, ulcers. So we have the first 7 on the screen here, and then we have the other 6 right here. Okay, and again, uh, um, just like the improvement indicators, okay, these QIs are calculated using those same temporary variables. And when we look at these QIs, we need to remember, right? These are flags, they are not judgments. They signal a change that is worth investigating, not a final verdict on care quality. So let's go through each of these again. Now, the temporary variable slides are in the binder, right? They're in the manual. I don't need to go over them again. They're the exact same. They're just there for your reference, because the quality indicators associated with it are follow. So we're going to start with the percentage of resident whose status worsened on late loss ADLs. So these are essentially the mirror opposite of what we just reviewed. Not all of them. Okay, I'll address when they're not. But this one is the exact mirror as the other one. Well, there's a few caveats that we're going to address. So these are exactly the same. This one's different. So we have 4 items, right? We have transfer to toilet use, bed mobility, and eating. And the 0 to 8 is converted to 0 to 4. So 4 times 4 is 16. If someone has a score of 16, you know they are completely total dependence, or it didn't happen. So what they're saying here is, if your previous was 16, you can't get worse. There's no getting worse. So you're not part of this QI. The only way that someone was 16 previously is going to impact the QI for ADL late loss here is if they improved. And this calculation is the exact opposite. Instead of going down, we're going up, right? So let's say they were 8 before because they had all twos. Now we have 2, 2, 3, 3. So we're up by a factor of 2. These ones were all twos, now 2, 2, 2, and 4. Same thing, up by a factor of 2. So because these are disability scales, so because we've increased, essentially we've declined. Our score increases, our ADLs worsened. But for the late loss, you need to have a difference of a total of 2, right? It's a summary of all 4. If you're not excluded, you're part of that calculation. It's important, this one, right? It flags residents who are becoming more dependent in those core physical functions, something that should prompt care teams to explore, and probably modify those care plans accordingly. This is an important QI. We're flagging everybody that's declining in those essential daily functions. So identifying these changes helps the care team intervene early, whether it's through restorative care strategies, reevaluation of care goals, or making sure that supports are in place to preserve that quality of life. Same thing here, okay? This is essentially the exact same mirrored as the improved. The only difference, right, is they remain completely dependent. So we're looking at walking, locomotion, and transfer. So if your current score, right, your current score is higher, means you've worsened. Now, because you're saying, okay, if you were 12, there's 3 of them times 4, 12. You can't get more dependent than 12. If you're a 12 now, and you were previously a 12 now, then when we're looking at the improved indicator, it gave you credit for it. Now it's actually punishing you for it. It's not a good thing, because the improved one, you want a higher number. This one, you don't. But if you were completely dependent in these before, and you're still completely dependent, you're going to trigger this quality indicator. And then we move to this ADL indicator, which is also a mirror image of the improved one. We start with our exclusions again. Decision-making, end-stage palliative, current is missing, previous is missing. Now, before we move forward, I just want to address, so you've noticed how often this is here, right? And I spent a bit of time on it a couple of days ago. I just want to explain something, and again, this is a real story where I received a call from a home where they were saying that their system was malfunctioning because most of their quality indicators, everything was zero, zero qualified, zero triggered. It did not make sense. And this was a big home. They had 220 beds. So after I did my investigation, what we figured out was that the new ride coordinator would put everybody that moved into the home as end stage disease. So by putting them end stage disease, you're disqualifying them from a lot of those quality indicators. As you saw, there was only two or three that they would still be part of. That's why coding accuracy is very important. Okay, so this one is the exact opposite mirror as the improved ones. Okay, except them it was if there were zero and they're still zero, in this case is 8 and 8. So if they were totally dependent, right, we're talking hygiene and we're talking dressing, and dressing is the combination of the two. So if they were totally dependent, so 4 and 4, and they are and they were, then they have remained completely dependent, they trigger. So it flags early signs of decline in self-care tasks, right? These are tasks that are usually lost in that early functional deterioration. It's helpful, right, when we're trying to identify residents who may need enhanced support, or earlier intervention to try and slow the trajectory of decline. So, it directly, again, mirrors that improvement one. Decline in ADL. This one is not a mirror. This one, it doesn't exist in the improved. So it captures the overall decline in ADL self-performance. Okay, it's a summary score of 7 key ADL. It's a broader measure than the specific early, mid, or late loss indicators. And it's often used, right, to track the general trends in resident function over time. So when we look at the calculation here, we're using all of the ADLs except walking and transfer. Okay? So we're looking at the ADL long form outcome scale. That's what we're looking at. So we have our regular exclusion. If you're not excluded, you're part of the calculation, okay? So you're part of the denominator. Now, if your ADL score is higher, means you're doing worse, you've declined, you worsened. All right, again, this indicator is helpful for tracking that widespread functional decline, right? And it's especially useful at the system level. All right. Now, since it excludes walking and transfer, it focuses on those core ADL tasks related to daily care. It complements the other ADL indicators that we just reviewed. Again, this is just for your reference, okay? And this is the exact opposite of the improved one. So it, you know, is the percentage of residents whose behavioral symptoms worsened. We're identifying everybody that shows that it worsened, so it's an increase, right, in behavioral symptoms, and we're talking, right, aggression, wandering, inappropriate behaviors, those. Okay, so we're monitoring that behavioral health. Okay, we're going to try and take action to support the resident whose behaviors may be escalating or becoming more difficult to manage. right? Again, it is the counterpart to the other behavior one. So together, they allow the care team to track both that positive and that negative behavioral trend. So we're just looking at the score. If the current score again is higher, then you've declined. We're just adding them all up at 1 to 4, right? Confidence variable. So we've reviewed this. We don't need to review them again. It's the exact same as for the improved ones. All right. So we're focusing on resident whose bowel continence has worsened over time. So we're again using those temporary variables. Okay. And this measure, right, helps identify residents who may be experiencing that functional or medical decline that affects continence. So it could prompt a review, right, of the care plans, of the the everything that's related to toilet mobility, diet, medication side effects. So it's the exact same calculation as the improved. So exact same, except here is a 4 instead of a 0. So if they were a 4, it means they were completely incontinent. You can't get worse. So if you're already incontinent, we're not even going to look at you. Your current score is higher than the previous, you've declined. Same thing here, okay? Exact same calculations, exact same exclusion factors, right? Where if you were totally incontinent before, we're not going to look at you. You can't get any worse. So if your current score is higher than your previous, you've declined. The exact opposite mirror image as the improved one. Here we're talking about cognitive. And this one is the same as well, right? Is exact mirror opposite. So we're using your cognitive performance scale. Now, the only difference is if you were in the previous assessment, you coded a 6, so severely impaired. You can't get worse, so we're not even going to look at you. Now, if you were between a 0 and a 5, then yeah, now we're going to look. If your current CPS score is higher than your previous, you have declined, you will be part of the numerator. All right, communication variables, we are familiar with these. They're the exact same as previously. All right, so we're looking at decline in communication, right? It's part of the decline incidence indicators. It's again essentially the mirror image of the improved one. Okay. And just like its counterpart, right, it provides that essential insight into how well a resident is able to interact with others, to express their needs, to understand communication, which has a direct implication for safety, for care planning, and for resident engagement. It scored exactly the same. Um, we have our frequent flyers here. And if you were a 6 before, meaning it's as bad as it could get, you can't get any worse, we're not going to look at you. So if any of these are there, we're not calculating you. If they're not there, you're part of the denominator. And if your current score is higher than the previous, you've declined, you will be part of that numerator. Okay. And then mood is the same. We're using the depression rating scale, right? We're looking at that 0 to 14. It's important, right? In long-term care, because persistent, right, or worsening depressive symptoms can impact engagement in care, in appetite, in mobility, and even cognitive outcomes. So monitoring this quality indicator really helps to make sure that we are identifying and we are responding to those mental health needs early and appropriately. So if anything's missing, again, we can't calculate it. If your previous depression rating scale was 14, which is as high as it goes, right? You can't get much worse than a 14. So if you were already a 14, we're not going to look at you. If you're not excluded, then you're going to be part of the calculation, part of the denominator. If your current score is higher than your previous score, you've declined, you will be part of the numerator. I know I'm going fast through these worsening ones, but they're the exact mirror of the improvement ones. All right, it's almost 12. We're going to finish the quality indicator section before we break for lunch, and I'll make sure you all get your hour. So this one here, okay, it measures a functional decline in mobility, specifically tracking those residents whose ability to locomote has worsened since the previous assessment, right? Again, the mirror image of previously, of the improved one. And it's important, right? Declining mobility is again a major predictor of loss of independence, of increased falls risk, institutionalization. So monitoring it allows the team to identify those real early trends, right, and respond proactively, whether you're using physiotherapy, assistive devices, care plan adjustments. So we're using the one temporary score, 0 to 4. Now, if you were a 4 previously, right, you can't get worse, then we're not looking at you. If you're not excluded, none of these are there, then you will be part of the calculation. And in order to be the numerator, your score needs to be higher than the previous because that shows that you have declined. All right. So here we're talking about, and this one is not a mirror of the other one. Okay, this was not an improved one. So this is a new one. It focuses on residents whose pain levels have increased compared to their previous assessment. So we're looking at the pain scale. Okay, and remember the pain scale goes from 0 to 4, right? 0 and 1. Was not daily, and 2, 3, and 4 was daily, and depending on the level of or the intensity. So higher numbers reflect greater frequency and greater severity. and this is important, right? Uncontrolled or worsening pain impacts not only a resident's physical comfort, but their mental health, their mobility, their overall quality of life. So this indicator can help identify gaps, right, in pain management strategies, okay, and promptly, prompt timely reassessment or treatment plans. So this one for calculation, um, it, if your previous pain scale was already 3 or 4, it's at the worst end. You can't get worse. So we're not going to look at you. If any of the data is missing or the previous data is missing, we're not going to look at you. Now, pretty straightforward, right? If the current score is higher, then you've declined, you have more pain, you will trigger this indicator. Right, last quality indicator here, also not a mirror of previous of the improved ones. So this one helps us track residents who have a stage 2 to 4 that has increased in severity, right? It's gotten worse since the last assessment. So this measure is critical for monitoring skin integrity, evaluating the effectiveness of wound care interventions. Now, we don't have our frequent guilty party here for exclusion factors, okay? Because if they're palliative or if they're comatose, if they're end-stage disease, they can still get um, pressure ulcers. So what we're going to look at, if the data is missing, if the previous data is missing, if last assessment you were already a stage 4 or 5, you can't get worse than that. Okay. Now, if all the data is there and the last assessment, you did not have an ulcer or it was a stage 1 or less, then you will be part of that calculation because you're not excluded. Sorry, yeah. Previously, you had a stage 2 or 3. So we're looking for a stage 2 or 3 that got worse. So they have a stage 2 or higher right now, and the pressure severity has increased from the previous assessment. And the previous ulcer was lower than stage 4, because if they're stage 4 or then they're excluded, right? So if your pressure severity has went up, you've declined. Essential QI. It highlights the deterioration in wound healing. It may signal breakdowns in preventative care, repositioning routines, dressing changes. So a rise here should definitely for sure trigger a focus review of pressure ulcer prevention strategies within your home. All right, couple of quick questions. So, which of the following scenarios would most likely not trigger a decline incidence indicator? Their mid-loss ADL worsen, a newly occurring stage 3 ulcer, improved in communication ability, continence change from continent to incontinent. And we are correct. If a resident remains fully dependent in late loss ADL across two consecutive assessments, this would always trigger a decline indicator. Right? They reflect worsening or new onset. If the resident level of dependency unchanged, it does not constitute a decline. Okay. So if we take just a quick step back here, I know we reviewed a lot of stuff in a very short amount of time, but we didn't want to make this a 4-day course, right? So this morning we looked at 34 quality indicators, okay? And those are used in the inter-I LTCF system. And they're grounded into three types, right? We have the 12 prevalence indicators that tell us how widespread certain conditions or care practices are. We have the 9 improvement indicators that highlight positive changes in resident status. And then we have the 13 decline indicators, which help us flag deterioration in a resident's condition. So each of these indicators gives us a piece of the bigger picture when it comes to monitoring quality in our long-term care. So just a few notes, okay, as we wrap up, right? I really want to emphasize that these indicators are a measure of the care provided. They are not a final judgment, right? They are not meant to be judge and jury, okay? They're not judge and jury on your facility's quality. Instead, right, what they do is they help guide the quality improvement by identifying trends and supporting clinical decision making. And perhaps one of the most important things to remember, context matters. Each number here is tied to a real person, right? So reviewing quality indicators effectively means understanding the story and the circumstances behind that data. All right, we're going to break for lunch. I'll see you all at 10 after 1. We're almost there. Half a day to go, people. Thank you.